internal pressure sensation, lasting from a few minutes to as long as 4 hours. The pain doesn't come on with activity, but occasionally it's there when she's lying down. And her risk factors include hypertension and obesity. So putting it all together here, which of the following is true? A, she has a greater than 50% chance of having significant coronary disease. B, an exercise stress test would have a high degree of accuracy in this patient. C, exercise duration would not be useful in predicting prognosis. Or D, nuclear perfusion imaging would improve the accuracy of the exercise study. Okay, we had a bit of a spread here, but the correct answer is D. Nuclear perfusion imaging would improve the accuracy of the exercise study. So if you look at this patient again, I want to go back to the stem here. So she's 35 years old, so she falls into that low pretest probability range. Okay, so you start out with that. And then she has atypical chest pain. It doesn't happen with exertion. So we know it's not typical angina just from that. And she has a couple of risk factors. So she doesn't have a greater than 50% chance of having significant coronary disease. And we've just said she has a low pretest probability, so the exercise stress test alone wouldn't have a high degree of accuracy for her. We know that exercise duration is always useful in predicting prognosis, so it's not answer C. And so you're left with D. If you get the exercise study, you're going to need nuclear perfusion imaging to improve the accuracy of the test. Okay, next question. A 57-year-old man with lung cancer presents with 24 hours of increasing dyspnea. His blood pressure is 85/40. Neck veins are elevated, and here are his right heart pressures. RA pressure is 21. PA pressure is 45/20. Wedge is 21. What's the most likely diagnosis? A, pulmonary embolism. B, acute MI. C, SVC syndrome. D, tamponade, or E, pneumonia. Okay, a little bit of a spread, but the majority of you did get this right. The correct answer is D, tamponade. If you look at those right heart pressures again, you'll notice that the diastolic pressures are equalized. And in the setting of a presentation that's very classic for tamponade with hypotension and jugular venous distension, that all fits together and gives you your diagnosis of tamponade. The right heart pressures, all of them are elevated here from the wedge on back. So you have to choose something that is a possible cardiac complication of cancer from the stem, and that complication is causing the elevated pressures in both the left and the right heart. So of these, tamponade fits that bill. And if you're still wondering, you've got your pressures there that are equalized. That clinches the deal for you. Okay, so just again, key point here, diastolic pressures are equalized in all 4 chambers in cardiac tamponade. So let's look at our next question. A 63-year-old woman reports a history of effort-induced chest pain. On the treadmill test, she exercises for 4 METs, peak heart rate of 110, and has her typical pain. This is her ECG at rest. And this is her ECG with peak exercise. So what do you recommend? A, reassure the patient as this is a low-risk treadmill. B, repeat the test with nuclear perfusion imaging for greater accuracy. C, institute secondary prevention alone. D, refer her for cardiac cath. Or E, refer her to a psychiatrist for treatment of an anxiety disorder. Good. Okay, somebody said E. just to be that way. All right. Okay, she doesn't need to be referred to a psychiatrist. She needs cardiac cath because her ETT, her exercise treadmill test, was positive. She had at least 2 millimeters of horizontal ST depression in several leads on her peak exercise ECG. So that's a positive stress test. It indicates ischemia. You don't need any further testing. She can go straight to cath, and she needs to go straight to cath. And let's move on to the physical exam. Let's start with pulses. So, pulsus paradoxus is referred to on the exam as an inspiratory fall in systolic blood pressure. So, on inspiration, negative intrathoracic pressure causes the aortic pressure to fall normally, but normally it's less than 10 millimeters on inspiration. So, if the fall in inspiratory blood pressure is greater than 10 millimeters, that's considered significant for pulsus, and it occurs with pericardial tamponade, asthma, and tension pneumothorax. And that's just an example of the aortic pressure falling greatly greater than 10 millimeters in inspiration. Then there is the bifid arterial pulse, or pulsus bispheriens, which has 2 aortic peaks, and if you actually palpate the pulse of a patient who has this, you'll feel within 1 beat 2 separate bumps in the pulse. And this is consistent with aortic regurgitation, or hypertrophic cardiomyopathy can do this. Pulsus alternans, or the alternating arterial pulse, is caused by bigeminy, bigeminal premature ventricular contractions. And that's classic for severe LV dysfunction or severe aortic stenosis. Then there is the decreased rise time and volume of the arterial pulse, especially in the carotids. This is referred to as pulsus parvus et tardus and is classic for severe aortic stenosis. You might not see it in the elderly in spite of severe aortic stenosis, but usually it is a finding with severe AS. Other pulse abnormalities, aortic dissection causes asymmetrical pulses, usually normal in the upper extremities and absent in the lower. And then we know that peripheral artery disease can cause decreased or absent pulses in one or both legs. Okay, take a deep breath. We're going to move on to the JVP. This is everybody's favorite, but I'm going to explain to you the physiology behind this, and it might make more sense. So, the waves of the jugular venous pulse. Let's start with the A wave. This is when the atrium is full, think A for atrium, and it contracts against an open tricuspid valve. So the atrium contracting gives you a big bump, the A wave. In fact, the tallest wave of the JVP comes from the atrium contracting. Then the atrium relaxes with the tricuspid valve closed, and you get the X descent, which is the largest descent. So atrium contracting is the largest positive waveform. Atrium relaxing is the longest descent, the X descent. Then it's got to fill back up, and so as the atrium is filling, the JVP rises, and at the peak filling, with the tricuspid valve still closed, you get the V wave. Then the tricuspid valve opens, and the atrium starts to empty, and you get the Y descent, which is a short descent leading back up to the A wave because it has to contract to completely empty. Okay, so think of starting with A for atrium contraction, and then completely emptying down to the X descent, and then filling up again, but the tricuspid valve hasn't opened. You get your V wave. And then the tricuspid valve opens, and the atrium starts to empty. You get your Y descent. And then to finish emptying, you have to come back up to the contraction of the A wave. Okay, now you'll be happy to hear that you won't be given a JVP finding in and of itself on the exam and expect to know everything from that. But it can be included in the stem of a question, and it can give you some really good information and help you make that multiple choice option correctly. So here are some findings that are associated with pathology that might tip you off. Large A waves, So if you go back and look, remember, A, atrium contracting. So if the A wave is larger than usual, something is preventing the atrium from contracting and emptying all the way. That would be tricuspid stenosis. Or severe pulmonic stenosis that has backed up everything into the right atrium. Same thing with RVH. A severe non-compliant right ventricle that's hypertrophied will prevent that atrium from contracting effectively and emptying effectively. That would all give you a large A wave. Now this is pretty classic. You want to know this one. Irregular Cannon A waves. These indicate AV dissociation. So if you see a description of irregular Cannon A waves, automatically think AV dissociation is going on here for some reason or another. They occur in 70% of ventricular tachycardia, which is characterized by AV dissociation. And then you know third-degree AV block is characterized by AV dissociation. Those are the two to be concerned about. So here, if you look at the P waves, they're marching on through on their own, some of them in the QRS, some of them in the T. They're doing their own thing, irrespective of what the ventricle is doing. These, when they correspond to the QRS complex, will cause an irregular Cannon A wave because it's the atrium trying to contract against a closed valve because the ventricle isn't in sync with it. So that is AV dissociation. This is ventricular tachycardia, by the way. Same thing with third-degree AV block. You get those irregular Cannon A waves when the P wave that's marching through on its own happens to coincide with a QRS. And then bang, you get this Cannon A wave back into the JVP. Then the rapid X and Y descents. Why would the atrium just unload itself? That happens in constrictive pericarditis if both are present. If the Y descent is absent and there's only a rapid X descent, think of tamponade. So we'll hit this again later, but this is one of the ways to tell a difference, if it's given to you, between constrictive pericarditis and tamponade, and that is the characterization of the JVP. Pericarditis has both rapid X and Y. Tamponade only has the rapid X. Y will be lost. Okay, so we have gone over most of the ones you need to worry about, and you can look at this table on your own for summary. Let's go on to this question. A patient presents with complete heart block. What pattern of neck elevation do you expect to see? A, absent A waves and a slow Y descent. B, large A waves and V waves. C, rapid X and Y descents. D, Cannon A waves. Or E, distended neck veins with no pulsatile activity. Excellent. We got this point driven home. The correct answer is D, Cannon A waves. That's AV dissociation. Okay, next question. A 45-year-old male presents with several days of fever and tachypnea. His history is positive for IV drug use. On exam, there are large V waves in the JVP. There is a 3 out of 6 holosystolic murmur best heard at the left lower sternal border that increases in intensity upon inspiration. So an echo would likely show A, aortic stenosis, B, an anterior wall motion abnormality, C, moderate to severe tricuspid regurg with a vegetation on the tricuspid valve, D, cardiac tamponade physiology, or E, pulmonic stenosis. Great. The majority of you got this correct. Answer C is the only one that makes sense in this scenario because I've given you a classic case, classic presentation of drug-induced endocarditis, and this has got a vegetation on the tricuspid valve. So that gives it away even if you don't know what's going on with the JVP, even if you can't remember what those waves are supposed to represent. So that's an example of how the JVP findings often will appear on the board exam. Let's go on to heart sounds. Now this is just showing you a picture of, this is the aortic valve on transthoracic echocardiogram. This is the mitral valve. And it's showing you some normal mitral valve motion. And it's to drive home the point that the first heart sound, S1, comes from the closure of the mitral and tricuspid valves. And so changes in intensity of S1 reflect processes that affect closure of those valves. So if you have a decrease in the intensity of S1, the mitral valve isn't closing as effectively. Think of mitral regurgitation or acute aortic regurgitation, which can affect the mitral valve because, as you saw in that echo, they're very close together. A severely calcified mitral valve won't close normally. Okay, so that's a change in S1. Now, increase in the intensity of S1 is caused by the closure of the leaflets when they're stiffened. So the mitral valve slams shut. You can think of it that way. And that happens with hyperdynamic LV function and also with mitral stenosis. The second heart sound, S2, is generated by the closure of the aortic and the pulmonic valves in that order. So to remember the normal order of valve closure, you can think of this mnemonic, MTAP, mitral, tricuspid, aortic, pulmonic. That's the normal valve closure. So let's talk more about S2. Normally, physiologically, S2 is single during expiration and slightly split during inspiration. That's because increased venous return during inspiration increases the volume in the right ventricle, and that causes the right ventricle to empty late, and then the pulmonic valve closes late. Now, persistently split S2 is where the S2 is split in inspiration and expiration, but a key point here is that it widens farther during inspiration. So the pulmonic valve is taking longer to close, and it causes a widened S2, and that could be seen in pulmonic stenosis or right bundle. Also, early closure of the aortic valve can also cause a wide S2. So think of persistently split S2 as a widened S2. It's split during both inspiration and expiration, but it splits even farther during inspiration. Now, this is a pearl. If it's associated with an ejection click that disappears with inspiration, think of pulmonic stenosis. That's a favorite on the board exam because it's the only thing that does that. Ejection click disappears with inspiration, and there's a persistently split or widened S2, think of pulmonic stenosis. Now, what about paradoxically split S2? That's when the splitting occurs during expiration instead of inspiration. And that happens in cases where the left ventricle has delayed emptying, and therefore the aortic valve is delayed in closing. So P2 happens before A2, and that happens with aortic stenosis if it's severe, and with left bundle branch block. So paradoxically split S2 is pretty common in left bundle branch block. Then there's the fixed split S2. It is present in inspiration and expiration, but it doesn't change. The duration of the splitting does not vary throughout the respiratory cycle. It's always split, and it's always split in the same duration, and that is classic for ASD, atrial septal defect. In fact, it's pathognomonic for atrial septal defect. So what's the difference between persistently split S2 and fixed split S2? Persistently split S2 is where the splitting changes. While it is split in both inspiration and expiration, it splits more in inspiration. With fixed split S2, it doesn't split more, it's just always split the same way, again and again throughout the respiratory cycle. So fixed split S2 means ASD. Okay, and that's just an example of how the splitting can occur. With the widely split S2, splitting even more in inspiration here. Okay, let's talk about the pulmonic ejection sound for a second. If there is an ejection sound that's common for congenital pulmonic stenosis, I told you about the ejection click, and it's the only right-sided sound that becomes softer in inspiration. That's why it's a favorite exam question. So just hammering that one home. Now, S3, the third heart sound, occurs only in certain cases. It's heard in early diastole when it does occur. With rapid passive filling of a stiff ventricle, it's caused primarily by ventricular dysfunction, and it's a very bad prognostic sign in patients who have known LV dysfunction or in patients who are about to go to surgery and have known heart disease. The S4 sound occurs in late diastole, just before S1, and that's associated with ventricular stiffness or diastolic dysfunction. It can happen with CAD, aortic stenosis, MR, but I think of it mainly with hypertensive heart disease and left ventricular hypertrophy. Now, you need the atrial contraction in order to generate an S4. So you would never hear an S4 in someone who has true atrial fibrillation because the atrial contraction is lost. And you wouldn't hear it in mitral stenosis because the atrium can't contract effectively against a stiff mitral valve. So those are two situations where a patient could very well have any of these diseases and you wouldn't hear the S4. So let's look at this question. A young patient presents with a second heart sound that does not vary with respiration. ECG shows right ventricular hypertrophy and right atrial enlargement. So what's the most likely diagnosis? A, mitral stenosis, B, aortic stenosis, C, ventricular septal defect, D, atrial septal defect, or E, pulmonic stenosis. Okay, good. The majority of you remembered that fixed split S2, which is what was described by saying that it doesn't vary with respiration. That matches up with ASD. So the correct answer is D, atrial septal defect. Now for the next question, we've got a 22-year-old woman who presents with some mild dyspnea on exertion. So you hear a 3 out of 6 systolic ejection murmur, but it's best at the upper sternal border. And there is fixed splitting of S2. So what diagnosis do you suspect? A, ventricular septal defect, B, aortic coarctation, C, ASD, D, congenital pulmonic stenosis, or E, an innocent ejection murmur. Great, 88% got this one correct. The correct answer is C, atrial septal defect. Remember, fixed S2, fixed split S2 equals atrial septal defect. There shouldn't be any confusion after that point. We should get 100% on this. Fixed split S2 equals atrial septal defect, okay? Okay, next question. Which of the following on a pre-op evaluation indicates the highest risk of these choices? A, an S3 on exam. B, an S4 on exam. C, left bundle. D, right bundle. Or E, left ventricular hypertrophy as seen on an echo. Okay, yes, the correct answer is S3. Answer A and S3 on exam, because remember that is the heart sound that indicates severe LV dysfunction. And so that's associated with high risk. Any patient going into an operation with severe LV dysfunction is going to be at high risk for complications and even death. Of these options, the S3 is the only one that gives you a very clear indication of severe LV dysfunction. Okay, murmurs we will talk about when we get to the valvular heart disease section with each valve. So we have time to go ahead and move on to one of the biggest sections here, coronary artery disease and myocardial ischemia. And just by way of overview, let's talk about angina. So angina is caused by a mismatch of oxygen supply and demand, and you have either stable or unstable angina. Stable angina is usually due to concentric plaques, whereas unstable angina is usually due to a ruptured plaque. Now, as important as angina is, only about 20% of patients with ischemic ST changes on ECG will also present with angina. And this is just to show the stable plaque versus the ruptured plaque. The ruptured plaque is the cause of unstable angina and myocardial infarction, acute coronary syndrome, basically. Okay, so as I was talking about with the S3 heart sound, LV function is the most powerful risk stratification parameter in all of cardiology. So we always want to know how a person's ventricle is functioning and how well it's doing, because that tells us a lot about prognosis. The next is exercise capacity in METs. That's highly predictive of prognosis. The farther someone can go on a Bruce treadmill test, the better off they're going to be in the long run. And then the severity of angina. The more severe the angina is on presentation, that actually portends a poorer prognosis. So how do we do risk assessment in asymptomatic patients? And remember, throughout this, we're talking about asymptomatic patients. So according to the AHA-ACC guidelines from 2013 on risk assessment, all asymptomatic adults who you don't already know have coronary heart disease should have a risk score calculated. And there is a risk calculator available online, or you can use the older calculators, which are also available online, Framingham or Reynolds. But most of us have gone to using this one, the AHA-ACC Atherosclerotic Cardiovascular Disease Calculator. You can just Google that term and you'll come up with a risk calculator that looks a little bit like this, and you can plug in some values. So let's plug in some values that are pretty high risk and see what comes out. So if we have a patient who has male sex, is 63 years old, is African American, has a pretty high total cholesterol and a low HDL, has a high blood pressure and is on treatment for blood pressure, and is diabetic and is a smoker, okay, I don't have to tell you that's a high-risk patient, right? But if you did put that into the calculator, you would see an estimate or a calculation of 10-year and lifetime risks. And for some reason, we don't have the lifetime risk showing up here, but you would get that. It's probably off the chart, but you would get that if you plug this in online. And so what this shows is this patient has nearly a 70% 10-year risk of having a coronary or cardiovascular event. The nice thing about the ASCVD calculator is it takes into consideration the higher risk that different populations have. So for instance, African Americans are at higher risk for certain diseases than cardiovascular diseases than Caucasian Americans, and women are at much higher risk for stroke than are men. And it takes this into account. It's all built into the calculator. So I encourage you to go and play around with that online. You can put your own risk factors in if you want to. And you can see how if you change just a little bit, how this risk score can really change. You'll see that certain risk factors carry greater weight, especially age and diabetes and smoking. Those things really make a difference. Now, what do you do with this risk calculation? Well, it's meant to be used for a discussion regarding statin therapy and for how aggressive to be with your medical treatment, because this is still an asymptomatic patient, remember. So anybody who has a 10-year risk score of 7.5% or higher based on that risk calculator I just showed you, or on any of the other risk calculators. This one just happens to be highly accurate down to the 0.5%. If you're at least 7.5% over 10 years, that patient should be on a statin. So that is the guideline that will probably show up on your boards, that 7.5%. Now, it's important to know what we mean when we talk about these risk categories. So in general, someone who is less than 10% has a low risk of having a hard coronary heart disease event in 10 years. Someone who's in the 10 to 20% range is of intermediate risk, and someone who is greater than 20% has a high risk. And we'll use that for management. I'll show you in a moment. The other recommended assessments is that you get a family history about cardiovascular disease, get the lipid profile in all asymptomatic patients, get a resting ECG if the patient has hypertension or diabetes. And for a patient at intermediate risk, this is where your risk calculation starts to come in, it is reasonable to get a measurement of ABI, ankle brachial index, looking for peripheral artery disease, because that is more common in patients as the risk calculation goes up. Also, for patients at intermediate risk, it's reasonable to get a coronary artery score, coronary artery calcium score. Again, that's not the CTA, that's just the basic calcium score. And in patients who are over the age of 40 with diabetes, you can also measure that coronary calcium score. Okay, what's not recommended is that you be measuring advanced lipid parameters like the advanced lipoprotein studies in asymptomatic patients who you're not following specifically for a lipid disorder. This is just a screening. It's not recommended to do advanced lipids as screening. It's not recommended to do genotype testing at this point, or to do a BNP measurement in someone who is asymptomatic. It's not recommended that you get a C-reactive protein measurement if you know the patient is already high risk, because that doesn't add anything to your analysis. You already know they're high risk. Similarly, you don't need to get the CRP in patients who are low risk and who are on the younger end of the age spectrum, because you know they're low risk and it's not going to add a whole lot. Don't get echoes in patients who don't have hypertension or in patients who are asymptomatic. Also, you don't need to do flow-mediated dilation studies or any other measures of arterial stiffness outside of research settings. And then stress echo is not recommended in asymptomatic patients who aren't high risk. Also not recommended is a stress nuclear study in a low or intermediate risk asymptomatic patient. Low-risk patients don't need a measurement of coronary calcium. You just accept that they're low risk by the calculator. And don't do a CT angiogram in an asymptomatic patient ever. So what do we do to modify risk? Well, first you need to understand the risk factors, and these are most of the traditional risk factors for coronary disease: age, and for personal history. For a male patient, it's age over 45 becomes a risk factor for CAD. For a female patient, it's her personal age over 55 that becomes a risk factor for CAD. So it's separated by 10 years for men and women, because we know male sex in itself is a risk factor for CAD. Then, for family history of premature CAD, what we mean by that is if the patient has a first-degree relative who is a male and had CAD at the age of 55 or less, okay? So it's just shifted a bit. For a female relative who had CAD at the age of 65 or less. So those are the 10-year age range. For the patient himself or herself, for the male patient, if he is 45 or older, he's at risk for CAD by age. If the female patient is 55 or older, she's at risk for CAD. If a patient has a mother who had CAD before she turned 65, that's a premature family history. Okay, so I just want to be clear on those terms. Then we know dyslipidemia, smoking, chronic stress has now been identified as a clear risk factor for CAD. Sleep disorders like obstructive sleep apnea are risk factors. Hypertension, diabetes, obesity, sedentary lifestyle, postmenopausal status, you know those. Peripheral artery disease, if someone has, or other known vascular disease anywhere begets vascular disease elsewhere. So someone who is known to have any kind of vascular disease in the aorta, in the carotids, is at risk for coronary disease. And then chronic kidney disease is a risk factor in and of itself. So let's look at this question. In a 55-year-old man, which of the following risk factors is most predictive of the presence of coronary artery disease? Is it A, an LDL cholesterol of 120, B, a fasting blood glucose of 160, C, a 20-pack year history of smoking, stopping 5 years previously, D, LVH on an ECG, or the father died of an MI at age 68? Okay, a bit of a spread here. The correct answer is B, a fasting blood glucose of 160, because that makes the diagnosis of diabetes. And diabetes is a very strong risk factor for coronary artery disease. It carries a lot of weight. Not many of you said LDL cholesterol of 120, and that's good because it's still less than 160 and 190. We'll go over those values in a moment. But it's still low enough that it's not going to be the most predictive risk factor of what's listed here. Many of you picked this one, a 20-pack year history of smoking. But the patient stopped 5 years previously, and we know that within 1 or 2 years, someone with a smoking history, if they've stopped, their risk drops to that as if they had never smoked, to that of a non-smoker, when it comes to coronary disease, not lung disease, coronary disease. So this is an added encouragement to patients to stop smoking because they can reverse a lot of that risk. LVH on an ECG, we don't know anything more about this, whether or not this patient has hypertension, whether or not they really have LVH on their echo. So go with the numbers here. The fasting blood glucose of 160 is definite diabetes. And then in terms of the age of 68, I already went over the age ranges. If the father had been less than 55, that would have been premature coronary disease. But even that would not have outweighed a personal risk of diabetes. So that's the point here. Okay, next question. A 30-year-old woman with a BMI of 34.5 and a family history of premature CAD presents for her annual visit. Her blood pressure is 120/80 and she has no complaints. So what do you recommend? Coronary artery calcium scoring, an exercise treadmill test, right heart pressures, weight loss counseling, or a stress echo? Great, great. The vast majority of you got this correct. It is weight loss counseling. She had a BMI of 34.5. She's obese. She needs to have weight loss counseling. She's asymptomatic, so she doesn't need any further testing. And she's low risk, so she doesn't need coronary artery calcium scoring at this point. Okay, I mentioned before that there are statin benefit groups. So what are those groups? According to the 2013 Blood Cholesterol and Risk Assessment Guidelines by the ACC-AHA, there are 4 groups for both secondary and primary prevention. Number 1 is the patient who has known clinical atherosclerotic cardiovascular disease. And that can be anywhere, in the coronaries, in the peripheral arteries, in the brain with a prior stroke or TIA. That's a clear statin benefit group. The second patient is the one who has an LDL level of at least 190, and that captures all the patients who have familial hypercholesterolemia. Then there's the patient who is in the age range of 40 to 75 who has diabetes and an LDL that's in the range of 70 to 189. So basically, a patient in that age range with diabetes whose LDL isn't already less than 70 should be on a statin. And a lot of us will automatically put all diabetic patients on a statin. The fourth group are those who don't fall into any of these other categories, but they have that 10-year risk calculation that we talked about before of at least 7.5%. And there is a recommendation about statin intensity depending upon the group. So high-intensity statins are those that lower LDL cholesterol by at least 50% on average, and that of the available statins is atorvastatin 40 to 80 milligrams, or rosuvastatin 20 to 40 milligrams. Those are our high-intensity statins. A moderate intensity statin lowers LDL by 30 to less than 50%. That's how that is defined. And that's basically all the other statins that are available, and the lower doses of atorvastatin and rosuvastatin will be moderate intensity. I do want to make a note here about PCSK9 inhibitors, which have been all the rage in the past year in the lipid community. These are like evolocumab, alirocumab, the new inhibitors that really lower LDL very, very low. They're not currently indicated for primary prevention of CAD. What they're approved for, what you need to know, is that they're indicated in patients with familial hypercholesterolemia, or high-risk patients who have known coronary disease, and you can't get them to greater than 50% lowering with your high-intensity statin. So your statin isn't working, and they're a particularly high-risk patient. That's who gets PCSK9 inhibitors. Not for people who don't have known CAD or who don't have familial hypercholesterolemia. Okay? It's anybody's guess as to whether or not that'll show up on the boards this year because they were just approved around last spring or last summer, but it's a possibility. Okay, moving on to HDL cholesterol. To say that our understanding of HDL cholesterol is still evolving is a gross understatement because a lot of trials now have shown that there's no benefit to raising HDL alone. Niacin trials, the CETP inhibitors have all fallen flat, and in fact, some of them have increased mortality. So we can't really figure out what is going on there with HDL. But what you need to know is we don't treat HDL cholesterol anymore with a pharmacologic agent. Okay, there's no indication for raising HDL cholesterol at this time. If you see somebody who has a low HDL, just know that they are at higher risk for CAD and treat other risk factors. So, aerobic exercise is one of the interventions or lifestyle changes that can increase HDL cholesterol, and it has a lot of benefits in and of itself. Estrogens, and these are primarily intrinsic estrogens, not hormonal replacement therapy, and small amounts of alcohol that have been shown to increase HDL. HDL is decreased by smoking and by androgens like testosterone. That's why men naturally have a lower level of HDL cholesterol, and another great reason to advocate smoking cessation. Also, HDL is often low in patients who have high triglycerides, as in your diabetic patients. There's an inverse relationship there. And so what I mentioned before, the benefits of smoking cessation begin within 48 hours, and within a couple of years, the CAD risk is the same as if it had been a non-smoker. Now, blood pressure control. So, there is some controversy about this, but according to the JNC 7 guidelines, which is what were the last true consensus guidelines, it's recommended in all patients who have a blood pressure of 140/90 or higher, and in patients with diabetes or chronic kidney disease, their blood pressure should be a little lower, 130/80. So there was a landmark trial, the SPRINT trial you may have heard of, that was released in the latter half of 2015, and it was stopped early due to clear benefit. And this trial showed improved outcomes at blood pressures that were aggressively lowered to less than 120/80. It has since been validated by a large Lancet meta-analysis as well as by smaller RCTs and registries. And what they did was they tested the systolic blood pressure target that was advocated in the last guidelines, JNC 7, of less than 140, versus a more aggressive target of 120. And these were in patients who were at least 50 years of age and at increased risk. And what they found was that when they could lower the blood pressure, systolic blood pressure, to less than 120, they got a 27% reduction in all-cause mortality and a 38% reduction in heart failure. And that's highly significant. Again, it was stopped early due to these results. It made a lot of headlines. It was big news, and I think we can expect it to have an impact on the upcoming blood pressure guidelines, which are to be released by the AHA-ACC probably later this year. For now, for your boards, which you'll probably take before any new guidelines come out, know that they tend to avoid controversy on the boards, so it would be something that's very clear-cut. For instance, you just need to recognize that the blood pressure is very high. They'll give you a blood pressure 165 over 95, and everybody can agree that that needs to be treated. Okay, so there won't be these gray areas on your boards this year. Okay, what about aspirin for primary prevention? And you all know the difference between primary and secondary prevention.